Ladies and gentlemen, it is time for this program to begin. If everyone is ready, I see we have a good group of panelists. We have almost 40 attendees right now. I'm sure that number will be growing. So if all our panelists are ready, I think we'll go ahead and begin. I'm Dave Meinhardt in suburban Detroit. I'm with the Vatiquity Foundation. I want to welcome everybody here today for this important webinar on oh God, I'm having a virtual medicine in India, the current status and future of virtual medicine in India. And we have a large group of panelists, and I'm going to let my boss, Vatiquity Foundation CEO, Dr. Mahendra Bhandari, introduce everybody and begin this program formally. Thanks for being here today. I'm going to get on the sidelines now.
Thank you, Dave. If you get on the sideline, we cannot survive. So you are the center of the stage. At the outset, I extend a very warm welcome to all the participants, which is, if I take the measure of the previous webinars, our participants are from 22 to 25 countries across, of course, mainly from India. For those who are joining first time, Vatiquity Foundation is a not-for-profit organization based out of Detroit and is the responsible for the birth of robotic surgery. And since then, our mission is we try to educate surgeons to use new technology, leverage new technology for developing new procedures. And at the same time, we experience down the line that until the recipient of this or beneficiary of these technologies is also mentally prepared. So we of late started training patients also. And we try to bring in pertinent subjects at the right time for public debate. It was the genesis of this webinar is few weeks ago, we had done a webinar with some of the common participants, which are present today, on telemedicine. And that was done to really look at the current status of telemedicine in India. Particularly, the subject was pertinent because of the COVID times. It was somewhere close to the second wave of COVID in India. And at that time, it was a very largely participated webinar. And during this discussion, I thought that one angle was missing because telemedicine has several facets. It has a technological angle, it has the last mile problems, it has connectivity issues, it has acceptability by physicians and all. And then through WhatsApp communication, I tickled Vidya whether we could do part 2 of the telemedicine, bringing what is the physician acceptability to this, whether it is going to wither with the wave of the COVID or we are going to see a resurgence of telemedicine as it is being observed in the rest of the globe. And that's how I must congratulate Vidya to have worked so hard and put one of the best panelists because I had the taste of it in the rehearsal she conducted a few days ago. I think to set the ball, I've set, though their content I have seen is excellent, there's nothing, in fact, there's a lot of learning for me. But I would like to set the ball roll by setting the objectives for this. The purpose is not to offload the knowledge of your subspecialties in telemedicine, and that's why you are sitting in this August panel. Purpose is to really, to educate. How can we really, telemedicine either or physical medicine, either or is not going to do. They are complemented to each other, and we are looking for an ideal hybrid. And what is that ideal hybrid? Which would improve the quality of patient care, bring down the cost of the medicine, take away the extra load from the hospital for the unnecessary patients. What kind of technologies we can bring in. And second is, one is patient acceptability, then the environmental acceptability, And the third thing is the physician acceptability and the business angle of telemedicine, which would be brought in. Because hospitals have not done their homework as I interact with most of them, and they are really enamored with the inpatient heavy hospital system, or what you call eminence based medicine, and they are not really wholeheartedly accepting it. Uh, if my take is that most of it was, except for the players who were already in it, most of them were doing telemedicine. Most of it was a compulsion because they wanted to really catch up with during the COVID time, and there was no other option to keep their teams safe. But I feel, and I have no data, but I have in my mind calculated that telemedicine is the only way for them to enhance their business, keep containing the infrastructural overload in the hospital, which goes a long way to compromise the quality of care. So, with all expectations and excitement, I pass it on the baton to Vidya. I had known her as Vidya Govindrajan, now she is Mohan. And certainly, Vidya, when she was at Zipmer, I have very vivid memories of her, did not evince that level of uh, confidence and the commitment which I see now. So I'm really happy and to know her for so many years. Vidya, it's all yours. Thank you very much for conducting this. And I, on the behalf of Foundation, once again felicitate and thank all the speakers and look forward to a very interesting session. Vidya.
Thank you so much for your kind words, sir. And first of all, I'd like to thank Patta Radhakrishnan for setting me on this journey of marvelous medicine. And thank you, Dr. Bandari, for posing your faith in me in conducting this program. Since you have already made the introductions, I will just get on to the topic right away. Just to repeat that we are in a unique position to use this momentum that COVID has brought to bring virtual medicine into the mainstream of medical care in post COVID India. And we have put together a panel to take you through what is happening in the field of telemedicine in India today, how anyone from a general practitioner to a super specialist can use telemedicine to deliver patient care, what the challenges we will encounter while following the current guidelines which the government of India has rolled out, and whether any modifications are needed for that, how the leaders in both the private and public sector are handling this transition, and how virtual medicine can lend itself to public service initiatives, and what business opportunities are there in this budding industry. Due to lack of time, we will not be discussing anything advanced like remote surgery or medical education today. So, without further ado, I introduce you to the first panelist, Vetturi Prabhakar Murthy. Prabhakar runs a private pediatric practice in Bangalore, and he has been using a hybrid model of in person and virtual consultation since the beginning of the pandemic. Prabhakar, welcome. Could you take us through the
Thank you, Vidya.
process of how you started your virtual consultations, the difficulties you faced, and how you
Yeah,
overcame them in a standalone practice? This is likely to be highly useful for any practitioners who are logged in. Over to you, Prabhakar.
yeah. Thank you, Vidya. Thank you, Dr. Bandari and the Vatikudi Foundation. Uh, Disclaimer straight away. I'll probably be setting the ball rolling because it's going to be the very base minimum that telemedicine has helped, and I'm pretty sure I'm just one of thousands of doctors who actually successfully used uh, uh, this platform during the pandemic. Of course, as we all know, the need started off with the starting of the pandemic in India near about March when there was a lockdown, and we had to we were not sure what to do. We had to close our clinics. Even the government was not 100% sure. Uh, am I audible now? Is there some problem with the audio?
This is better, Prabhakar. Now you're better.
Yeah, yeah, okay, fine. Just let me know if I'm not very audible. So, what happened was at that time, people like me who are in single practice had to close down for some time, at least for 15 days, 20 days. And we were not sure especially other people like slightly aging doctors who are more than me actually had to close down because they were scared of the pandemic. So the only way to actually go about it was to have telephonic or other way of consultation. Since I had some interest before, we had a way of telephonic consultation just to clear doubts of people and other things. So I just took it forward. So since there was time, I just looked around, looked for ways of connecting to patients in what way they would be able to connect. The main issue was what would be a comfortable platform for any kind of patient. I have a very varied kind of clientele, starting from middle class urban people to some rural population also. So obviously connectivity would be a problem, the use of devices would be a problem. So I did a bit of research. I hit upon a few websites which were offering free in face-to-face video calls. The problem about security and other things, I didn't know much about it. So there were things like secure face-to-face consultation which were promised by some of these websites. So I just blindly ran into it, and just around the same time, quickly the government put out the telemedicine guidelines. So how do we get the people to, I mean, how do you communicate to people was a problem. So luckily I had reception. So anybody who called the clinic would be asked to sort of sent a link on SMS and say, click on that link, you'll get diverted to that particular website. And that's how it started. And the problem was, if I had to use a platform which used an app download, that's something that would not be very easy for some of my patients. So I preferred something where they could actually get in. Hello? Is it okay? I have some disturbance here. Hello?
Hello, this is Dave in Detroit.
Yeah.
I ask all of our panelists to please turn off your microphones if you're not speaking, and we'll continue. There's some interference on Zoom. Sorry.
Am I clear now? Can you hear me? Yeah, okay. So that would have been a better way to do it. So I was not 100% sure of all the platforms like Skypes or WhatsApp and other things. So I preferred something that was online. So I started off with that. The second point was, how do I charge the patient for this? How much to charge? These are all things that came up. I'm pretty sure all of us went through this. Do I charge the same amount as my offline consultation, or do I charge a slightly lesser amount? I decided to start with a lesser amount than my online consultation. How do I collect it? Luckily here, I think the sudden spurt of online payment modalities in India after the demonetization really came to help. So therefore, I could actually send a link or tell my phone number so that people could transfer money to me as a consultation fee. Then came the problem of how well would patients take it. Initially, obviously, due to the pandemic and the lockdown, people weren't able to move. Therefore, it was quite easy to get people on board. So they did come on board, and it was okay. I'll get into the problems which we had. How I set it up. I just go quickly, and then I realized that initially for just a quick consultation, this was fine, but in the guidelines clearly said that we need to give a prescription and transfer it to the patient with the name clearly written, with the degree, the qualification, as well as the medical registration number. So that meant that I needed to transfer a document to the patient. That was not possible in some of these platforms. So then I looked for other things. So I gradually learned over a period of time, and ultimately with some search I settled down with one web platform. I'll not mention any names because I'm sure there are thousands of them. Many of us have used different ones. So in this, I've settled down by about say if this pandemic started by March, I was okay, settled down by about July, August, when the real peak has started. where I was able to actually prescribe and actually, to all practical purposes, follow the guidelines. While that was okay and patients were also happy, the main problem was sometimes the quality of the video would go down, the network quality would be poor, we wouldn't hear things properly. These are things that we naturally faced in the initial phases, and it continues even today, because sometimes the network does not work, especially if you're talking to somebody who's likely COVID positive. They're indoors, and indoors the network isn't very easily available, so that becomes a problem. Then certain disconnections, all these were always a problem, and many of these platforms would say pay first and then get onto the thing, in which case when I wanted a follow-up in 2 days, I generally don't take a follow-up fee after within the first week, so that would be a little bit of pressure on my patients, because they had to pay every time they had to contact me online. So I had to find some way around that, and maybe gave them my phone number and say you can call me for follow-up calls, etc. These are the basic teething problems. In the actual consultation, did I face any problem in pediatrics? Uh, Most of the time we interact with the parents, we get a lot of information for them, and luckily children are not very good actors, so their condition is quickly seen as with one quick look. Many times we were able to satisfy the need of the hour. So for most practical purposes, on an average, if I can say, more than 90-95% we were able to handle online only, without having a need to call them up for consultation offline. So in that way it was quite satisfactory. I didn't realize that we would be able to do this much. It's only after being put into the situation that this happened. Now gradually what has happened was, I'll show you a slide later on, that as the pandemic subsided towards October, November, the people preferred to come offline, and I was not able to drive that telemedicine consultation as much as before. So because people would anyway prefer to come, and the mobility increased, and they said no, we would like to come over and see. So overall, I think if I want to make a quick comment on general practice, because my clientele are very much near to where I practice, so most people would prefer to come in person. And telemedicine, the acceptability which Dr. Bandari was speaking, unless I drive it and say no, this is what I will do, the patient preference is still to come over and get checked up. Other than that, a few things which actually helped in the quality of the consultation itself was, one, availability of better networks, at least around the urban areas. Two, with the pandemic, people have started buying pulse oximeters. I mean, few gadgets which really help, and that added to the quality of the consultation, because we know that we can get at least one important vital sign from there, even though it's not very reliable in children, especially the smaller ones, but that actually helped. So to improve the quality of the consultation and quality information we are able to exchange with the patient, probably future developments in mobile gadgets and other things which can help in more exchange of information, more exchange of vital signs, etc., might be a way of going about it. I'll just quickly show one slide. Of how my practice went about over the last year and a half or so. On the x-axis here, y-axis here, I have the number of patients which I see, and below is the months. This is the total number of patients. I think this was just a reference. You can see that there is a marked decline in the number of patients we saw during the pandemic. And this is the total number of patients, and of course, being a pediatrician, at least quite a lot of them are actually for routine vaccinations, for which there is no option for online consultation. So if I actually take away the routine vaccinations, you'll find that the actual consultations which could have been done online or offline are in the dark blue uh, color. And you find that this sort of followed the wave of this thing. This is the first wave, this was the second wave. Okay, so this is how it's been going. So the number of patients whom I saw offline increased when the wave came down and decreased when the wave went up. So there are the number of patients who could have been seen online also. Compared to that, the red bars are the ones whom I've actually seen online. So you can see that in April it was quite near. May, it was quite near. June, July, August, September, you can find that the offline consultations slightly increased here. That was in the first wave. And then by Jan, Feb, when the wave went down, you can find that the number of patients online came down, almost disappeared. And then second wave started, and then there is suddenly rise. Even through this whole thing, you would realize that I've seen more patients offline than I've seen online. Only in May, because of the very heavy second wave, that I saw more patients offline on telemedicine than online. If you look at the ratio of patients, you'll find that this is the proportion. There's only once in May that I saw more patients on telemedicine than offline. So that's the situation at a general practice level. If you have any questions, I'll just go through them. I hope I have covered whatever I wanted to cover.
So, Prabhakar, we'll take audience questions at the end. We will finish
no
with our formal thing. Up next is Dr. Dilip Raman, intensivist and co-founder of Cloud Physician. Most of us are new entrants to virtual medicine, but Dilip and his company have been delivering high-tech, high-acuity care remotely for 5 years now. Dilip, could you please start your presentation on and give us an idea of how Cloud Physician works?
Yeah, hi. Good evening, everybody. I hope my slides are visible. This is Dilip here. I am an ICU and a lung specialist. I did my MBBS in India and then went on to do my fellowships in pulmonary and critical care at the Cleveland Clinic in the US. Being there for some time, we were closely involved in how a tertiary organization was looking to leverage its group of ICU doctors to cover a diverse set of ICU beds across a large nation. And they were facing similar challenges in how to ration ICU doctors and cover large number of beds with resource constraints with respect to ICU service delivery and ICU skills. And that parallel was nearly identical in India, but to a much, much larger degree. The deficit between trained ICU doctors and the requirement in India is pretty substantial. And as we all know in the West, that an intensive care unit should be run by an ICU specialist, also known as an intensivist, because that is what optimally improves the outcomes and survival of critically ill patients. The problem statement in India is much wider. So having realized that, we sort of wanted to come back to India and see if this tele-ICU model or the high acuity version of telemedicine was feasible and how it could be implemented in a resource constrained settings with all the diverse challenges that are there in the Indian ecosystem. So from a definition perspective, for an intensivist, this is I'm laying this up in front of you because we need to understand that probably about 1 in 10 patients in the ICU in India, 1 in 10 patients have access to an intensivist. So that's like 90% of Indian ICU patients do not get to see a fully trained intensivist during the course of their ICU stay. And to crystallize that thought further, it's important to understand that the healthcare ecosystem is faced with an iron triangle. And this iron triangle has 3 vertices that denote quality, cost, and access. And for this iron triangle to be broken so that you can actually give distributive access and high quality at a reasonable cost, you can give service, there are only very few tools that can achieve that at scale, and technology happens to be one of them. For instance, it's hard to give high quality critical care at low cost to a population the size of India. And really the problem statement was ripe to be solved. And that's where we thought that a rediscovery and a reapplication of tele-ICUs as they are in North America needs to be understood, broken down, and reassembled in a way that it will actually be useful for the Indian setting. I know there's a subsequent discussion on telemedicine guidelines and how they work, but from a tele-ICU perspective, what is relevant is that we are in a model that actually empowers the doctor. So in the sense, it is a registered medical practitioner augmenting another registered medical practitioner who then in turn helps the patient. So a typical tele-ICU, a telemedicine model that the speaker before me, doctor, was explaining was a doctor to patient through a screen model, which is RMP to a patient. In the tele-ICU space, in the high acuity space, you always need a doctor at bedside. So tele-ICUs do not replace bedside doctors, they augment them. And that is the model that we utilize in India and many parts of the world as well to run and operate a tele-ICU. How we do it at Cloud Physician is we take a computer vision based approach because of various challenges in India that involve devices not being connected to a central server or makes of these monitors being unsupported by technologies and them not being interoperable had sort of forced us to look at a solution that relies on cameras and a computer vision based technology that allows us to deploy and put our cameras there with our own firmware that talks to our platform. Allowing our doctors and nurses stationed in Bangalore, which is a city in South India, to connect to ICUs across the country. And the setup and the way that we are able to impart care is a very asset-light model. So you could probably describe it like an ICU or a tele-ICU in a box, because the models that are prevalent in the West are very resource intensive. They're very expensive. They require a very strong foundation on the part of the hospital to have an information technology stack so that you can build the tele-ICU platform on top of it. That is not the problem statement in India. In India, you have to start from scratch. Some of the hospitals are on paper. They don't have an electronic record system. So we had to work with them and design a platform built for the Indian context that can run on a mobile app, can run on a PC or a tablet, and can be run by a nurse who may not have the same expertise as a critical care nurse that you would find in a metro city or even in the US, for example. So just to give you an idea about how these systems work, these are images from our ICU in Bihar, which is a city called Motihari in Bihar. Actually, it's a township which is fairly remote, but we're able to see pristine images and videos of these ICUs in remote areas. This is just 90 kilometers from the Nepal border. And using our computer vision technology, we can actually parse this data and auto-populate the platform that allows us to digitize the patient record at this remote facility and allows our doctors and nurses in real time to support the bedside team to allow them to take better care of their patients. And these are images that also allow our doctors to help the patient's families. So, for example, a common question asked in India is that how are the patients going to respond to telemedicine and tele-ICU? And tele-ICU is obviously a lot more acute. The patients are sicker, so the emotions run high. And what we have found is pleasantly to our surprise that patients and their family members just want to have someone to talk to. And as long as they have access to a well-trained doctor and a well-trained nurse and a team, the bedside and us with a three-way conference with the patient's family are frequently able to allay their fears and actually enable them and us to deliver better care to their loved ones, which is really why we're all here in the first place. To give you just a brief idea what a day in the tele-ICU looks like, you have the bedside team on one hand, reviewing the patient, looking at the patient's data and sharing some of that data on the app. Some of the data is directly integrated into the platform and we can review the patient remotely from our screens here in Bangalore. All the documentation happens on a centralized platform. It could be any platform, it doesn't matter. And then the collaborative care starts where the doctor and the bedside doctor interact, discuss about the patient. The data is available on the go on their app so that they can do this during the busy part of the day when they're moving to the hospital. And then we have time for a collaborative approach where all the teammates and team members can get together and help in the care of the patient. So we're trying to do it as best as we can in a resource constrained setting. But the other important thing is that we do have access to India specific data, which we can bake into our analytics engine and then go back to the clinician and support them with a clinical decision support system. Now, early in the days, when this is being rolled out, the support system is obviously based on real world doctors and nurses talking to them. However, little by little, as the system matures, we're able to automate a lot of this. And some of this is already happening where the data would speak for itself and assist the bedside team in the day-to-day care of the patient. The key point here is that if telemedicine really has to have a global impact, it cannot be designed with the resource-rich states or the places where the technology is easier to penetrate. You need to drop the barrier so that the people who actually need the service can get the service. So our motto here is to frugally innovate as much as we can to lower the barrier so that these services can be adopted. They then become scalable because of their utility and optimize the care of the patients at scale precisely where they are needed. And you end up optimizing their outcomes and indeed saving lives in many cases. So to give you an example, even larger centers in India can actually leverage the strength of their intensivists to ration patients, because during COVID, we frequently saw that a COVID ward would be inundated with patients with varying levels of severity. So sometimes if you intelligently design your system, you could have an ICU doctor take care of 50 to 60 high dependency patients who are not on a ventilator without sacrificing their ability to take care of a critically ill ventilator patient. And that is exactly where a virtualized network comes in. You need to segregate and ration your resources so that these scarce resources are best deployed. For instance, India just has about 4,800 trained intensive care specialists. That is woefully low for 300,000 ICU beds that are projected to go live by the end of this year. And we're talking to governments where different state governments in India where they want to scale up the ICU infrastructure. But the problem statement is always going to be where the rubber hits the road. And that is, you can buy 100 ventilators and set up 100 ICU beds. How do you provide service to them? Now, the ideal use case would be to have the doctors at bedside, but clearly the training programs in India are going to take 25 to 30 years to catch up to that need. And the next best step is to actually leverage technology so that you can get this 360-degree view of the patient, utilize technologies that we have for digitization, that use machine learning tools and enable the bedside to go up and running with a plug and play model so that their critical care needs can be met at scale. These are some of the examples of things that we've already done pre-COVID and during our COVID deployments, where we've taken care of thousands of patients in that realm, where right now we've seen more than 20,000 patient bed days overall and about 4,000 COVID specific ICU patients, not ward, this is ICU alone. We're focused on the ICU. So to not belabor the point, some of these things get asked very frequently when I discuss technology and related aspects, not just in the ICU space, but also at large. Bedside manner needs to transition to website manner. And the cornerstone for that is effective communication. Training programs in India need to focus on the interpersonal aspect of healthcare, because that is what was neglected in India. And that is now coming to the forefront, because when you're faced with a screen, you've actually put a barrier there. So if your baseline interpersonal and communication skills are not good, it's going to be very hard for you to succeed as a telemedicine provider. So technology should be working in the background, and the clinician should be at the forefront, where less intrusive technology is more integrated into their workflow, because there are a few things that technology may not be able to replace, and that is the interpersonal aspect of healthcare. And if technology does all the heavy lifting in the background, that can really bring to the forefront the human aspect, which is sorely lacking. So to cut to the chase, tech will not replace healthcare providers, but over the next few years, healthcare providers who use technology will certainly and unequivocally replace those who do not. And that is something that we are very keen on looking as we go towards this space of not just tele-ICUs, but virtualizing an entire care paradigm. And this is becoming more and more evident. And COVID has just acted as a time machine. It's taken us in this time machine and zipped us past 5 years and 10 years into the future, where we really need to take stock of this, use the available tools that we have, and go towards a brighter future in healthcare, not just in the developing world, but also in the across the globe overall. So thanks for this opportunity. I'll conclude here and hopefully allow the discussion to proceed so that we can take up some interesting questions. Thank you.
Dilip, I'm sure everyone's waiting to ask you a lot of questions, but I'm going to ask everyone to be a little patient so that we can do the Q&A session towards the end. Coming up next is my colleague, Dr. Rajkumar Kulasekaran. He's a consultant interventional pulmonologist at Fortis Malad, Chennai. He started virtual COVID care during the pandemic and subsequently extended it for non-COVID and chronic respiratory care. Rajkumar, could you share your experience of virtual medicine in a corporate hospital setting, and what are your plans for the future?
Thank you, madam. It has been an excellent presentation by both of my previous speakers. They have spoken all the valid points, actually. I just want to share my experience, which I had for the last 18 months. To start with, COVID forced me to join the virtual medicine thing. It started with an COVID setup to evaluate my OP patients virtually, to assess whether they need admission or not, or to help my junior colleagues to assess the patient who are admitted in the COVID wards. This is how it started. Then it went on to my post-COVID patients, where they were more oxygen dependent, whom they have found it very difficult, a lot of logistical problems to come to the hospital to meet me during the COVID times. So that time, the virtual medicine played a huge role. Thereby, I could assess them through the pulse oximeter and everything, all the charts, and tell them what to do and what not to do with the nebulizations and all those stuff. And third thing, what I had was, many of us thought we could, without an auscultation, without hearing a wheeze or a crepitation, for a pulmonologist, we can treat any patient. But then I was proved wrong partially, because without auscultating, I'm able to treat the chronic ILD, bronchiectasis, and severe COPD patients who were oxygen dependent. They again found it very difficult to come to the hospital during the pandemic. Except for the ABG, which needs hospital help, all the other investigations, namely the chest X-ray, the labs, everything can be used at home itself. So I could send my people, my team from the hospital or the nearby setup to help the patient. So it was very, very useful for all the frail, old, severe COPD ILD patients. So it was really a boon for those patients. So who knows, in the near future, even an ABG can be done at home. That's the only thing which resisted me. The another useful point which I found was my regular patients, because of the work from home status, they went back to their hometown. For example, I had a tuberculous lymphadenitis young lady. Because of the work from home, she went to a tier 2 town, and she could continue the consultation for the next 6 to 9 months. It's a monthly checkup. So since I know her full history, I have examined her and everything, I was able to give the proper consultation virtually, and justifiably so. So there's a fourth point which I want to say. And the last of all, and many of us, because of we have treated COVID patients, and most of them are ventilator dependent patients with 100% oxygen or 90% oxygen. They were in different hospitals. We as colleagues, we were able to help each other when we wanted to give a second opinion. Sometimes few of our other hospitals, the family wanted a second opinion. So with the concurrence of the other colleague of mine in another hospital, as the Dr. Dilip said, the doctor screen doctor, we are able to give a second opinion virtually. Thereby, the patient and the family was very comfortable. The fact they are reinforced that the current treatment regimen is quite good. So please continue that. So for that, virtual medicine really helped to reinforcing the faith that whether the treatment going on is proper. For that, it was very useful. So they without a hassle, they could continue the ICU treatment in the existing hospital itself. These are the 5 positive things which I had during these last 18 months. Having said that, there are few negatives also. As Dr. Vetturi Prabhakar sir lucidly said, there have been network issues which I had, 1, 2, and yes, seeing a new patient, new pulmonology patient has always been a challenge. I couldn't assess even though I can use a peak flow meter, I couldn't assess the asthma and all those stuff. So new patients are always a challenge. As sir put a graph easily, yes, the ups and downs of virtual consultations were there based upon the pandemic. But then the virtual consultation is here to stay. How? As I said previously, everybody can't come to the hospital. Everybody need not come to the hospital. Supposedly, yesterday I had a patient with a motor neuron disease, the type 2 respiratory failure, who are in the home ventilator setting for the last 2 years. Usually, they come in an ambulance, come to the ER and wait for me. No, they did not come. I send my respiratory therapist to their home. He helped me to a virtual medicine consultation. It's all done for them. So it is very useful for that patient. So like this, there are so many examples. So virtual medicine is here to stay, to help us, to help all of us, doctors, the therapists, and the patients, whatnot. So this is my little experience for the last 18 months. I thank the Verticuity Foundation for the opportunity. Thank you.
Thank you, Dr. Rajkumar. You have spoken from the pulmonologist point of view, but I'm sure many other specialists from other specialties like rheumatology or cardiology all can get a take-home message from what you said, and they will also be able to leverage telemedicine to help their long-term patients who have great difficulty in traveling to the hospital. So, next up is Dr. Akash Ganju. He's the co-founder and CEO of Saath Health, which helps provide community healthcare services virtually. Akash, can you take us through how Saath Health helps to provide personalized healthcare and how you participate in health promotion and disease prevention?
Thank you. Can you hear me okay?
Yes, Akash.
Okay, great. So I'm Dr. Akash Kanji. I'm the co-founder and CEO of Saath Health. Quick background, I worked in the pharmaceutical industry for about 12 years, and then I've worked for the last decade at the intersection of public health technology and health consumer communications. Thank you for the opportunity to join this fascinating discussion and to share how Saath Health is building digital tools to personalize intervention for health consumers and patients. So there are 4 major trends that are shaping the future of healthcare delivery. These explain why health organizations, including your own, are investing in digital tools and why we are having this conversation today. World over, the burden of healthcare has been rising consistently, as is clear from the increasing impact of chronic diseases. We don't have enough healthcare workers. My previous speakers talked about this. The deficit in healthcare workers is actually projected to widen even more over the next 10 years. We just are struggling to meet the burgeoning demand from patients. So healthcare costs are rising very rapidly, and there is no evidence that they are going to stop doing so in the foreseeable future. This remains unsustainable for all of us. And finally, over the last 2 decades, there has been an increasing but unmistakable shift in health consumer adoption of digital tools. Patients increasingly want to participate in their own health journey, and this is also shaping a lot of how virtual medicine is shaping up. So these trends have led to increasing use of digital tools. We heard about from some of the other speakers, and I'm sure all of you have seen that in your own experience, but perhaps not as widespread as we might have expected. We recently spoke with about 50 senior healthcare executives to understand why, despite the optimism, digital tools are not as mainstream as might be expected. We learned 4 main things, and maybe these might echo your own experiences. The first and the biggest thing we heard is that there's a lot of silo solutions that don't scale beyond pilots or small settings because they don't integrate with existing care pathways. There's a lot of solutions that are not personalized enough for health workers and consumers. Health consumer insights are still largely based on clinic data. So we just don't know enough about what's happening with patients when they're not in the clinics. And finally, there's a lot of people that said that they have interesting analytics from digital solutions, but they don't really know how to change their practice with those analytics. So they're not able to convert those analytics into practical changes in processes and workflows. So for example, while hospitals, doctors, and patients have increasingly adopted digital tools, especially during the pandemic, the approach we feel is still being to digitize existing ways of doing business. And teleconsults and virtual consults are a good example of that. Instead, if we can reimagine care pathways to be digital first, we could find more effective ways of task shifting things like patient education, getting patients to self-monitor and self-report, creating risk stratified differentiated models of digital interventions, and in doing so, increase the clinic patient touchpoints while reducing the total cost of care. So our focus at Sath Health is to enable personalized interventions, and we use three primary tools to do that. We've built an AI-powered digital platform that provides a gamified, interactive, outcomes-based journey to end users. The platform is agnostic of indication. It doesn't really matter what we deploy it for. We end up providing a learning journey that modifies patient behaviors and nudges them towards predefined specific outcomes. Much like Netflix shows us content suited to our personal preferences, we built a health recommender system that surfaces content and nudges relevant content to users that is designed to direct them towards their target behaviors. And finally, we have a scientific and a creative communications team. Very often, I mean, our experience is that health communication is very boring. It turns people off. We are competing for patients' attention with YouTube, TikTok, everything that's out there, including entertainment. And whether we like it or not, without making health content flippant, it has to be interesting enough for patients and health consumers to want to engage with it. Health systems today are largely designed to respond to events and hence are transactional in their approach to patients. But patients have a convoluted journey. They don't go around thinking about their condition all the time. So if we want to shift their behaviors, we need tools to engage with patients even when they are not acutely in need of healthcare services. There's only so much our doctors and health professionals can do. So using smart digital tools can help build sustained community-based interactions with patients. This essentially means that while doctors and healthcare workers can focus on patients who are most symptomatic and uncontrolled, and that happens even now, most of the patients we see in hospitals are symptomatic and uncontrolled, but there is an underlying digital engine that can continue to engage other patients on behalf of the doctors. So there are two advantages to this. One, these tools can be an extension of the clinic and they can provide differentiated care based on the level of risk for patients. So somebody who's low or moderate risk, who's not necessarily knocking on your doors, can still continue to get a drip of intervention on behalf of the clinic. But equally importantly, the patient engagement with these tools can provide a rich source of insights on patient behaviors, attitudes, and perceptions. And this can be very useful to understand how to shift patients and drive them towards target outcomes. But these tools can only work if they're able to deeply personalize health consumer experiences. So it's not very different from how a physician would give different advice to a newly diagnosed diabetic versus a diabetic who's had a 20-year-old history of diabetes with multiple comorbidities. So we're building tools that can differentiate patient experiences based on several variables, including their indication, their geography, their gender, their clinical status, their risk stratification, and also digital phenotypes. And this is something that I want to speak about for 30 seconds, because very often adoption of digital tools is extremely poor in healthcare, especially when you compare it with other sectors. And we study a lot of digital consumption in other sectors. And what we've learned is that being able to segment and stratify digital behaviors by phenotypes can be a very powerful way of understanding and creating differentiated experiences for those patients. So based on all these variables, we adapt user experiences on the digital platform. We change the behavior change content, the nudge incentives, all of which is powered by our machine learning algorithms. So patients treating with osteoarthritis, for example, require a very different outcome than those who are recovering from cardiac surgery. So we build tools that adapt to the goals of these different indications. The end solution has a patient component, a patient interface, a doctor interface, and then underlying patient behavior analytics. We use personalized behavior modification tools to nudge patients towards the goals that are set for their indication. So very often when we speak with organizations, the question is, how do you measure if the digital tools that you're using actually make a difference? And there's a lot of people that we talk to who are unsure. They feel like something is positive, but they can't really articulate it. So we usually measure in our work the impact of these digital tools in 5 buckets of metrics. And depending on who you are, whether you're running an individual practice or a hospital, you can choose one or more of these based on those. So one is engagement. Are the patients actually engaging with these tools? How long are they engaging for? In what manner? Is it daily, weekly, monthly, once a quarter? So just that gives you a rich amount of insight about patient behaviors. Second is, are these tools teaching patients that you want them to learn? Is it increasing their knowledge about things you want them to learn? Are these tools getting them to do things you want them to do? Is it shifting their behaviors? The fourth is, are these tools improving hardcore clinical outcomes for your patients? For diabetics, is it actually improving HbA1c levels? Is it actually leading to better control of blood pressure? And the fifth is, which I think is as important as clinical outcomes, is, are these tools providing you with relevant business outcomes? And what I mean by that is, do these tools allow you to cater to more patients without increasing your time commitment? Or are you reducing the total cost of care by personalizing for risk? Do you now have better ability to track and prevent exacerbation of high risk cases, so on and so forth? So some of the metrics across these five might be relevant for your practice, but usually we find that most organizations will find a combination of metrics to track the digital performance of their tools within their practice. So that's what I wanted to share very briefly. We are moving towards an era of personalized medicine, and we believe that the right combination of digital tools can help doctors create very powerful personal experiences for their patients towards delivering positive outcomes, especially the patients who are not in your hospital today, but they might end up in your hospital because we have no way of engaging with them when they're back home in the community. Thank you very much for this opportunity, and I look forward to the discussion.
Thanks, Akash. Up next is Dr. Vasundhara Atre. She's the Director of Medical Operations of Fortis Healthcare. The Telemedicine Guidelines 2020 are the central framework around which virtual healthcare has to be delivered in India. So, Dr. Vasundhara, can you take us through the important aspects and throw some light on the barriers and medical legal implications of these guidelines? Dr. Vasundhara.
Thank you, Dr. Vidya, for that. And coming straight to the point, as we have been hearing, that telemedicine is all about timely access and actually getting access to medical care where otherwise it would not have been available. Interestingly, all of us have been actually practicing telemedicine in one form or the other. So whether it has been the telephone call from your patient or a WhatsApp message that you've been answering, directly or indirectly, we all have been practicing it. It was only in the wake of the corona pandemic that we faced last year, in March 2020, that we actually had a formalization of some guidelines relating to telemedicine. Till that time, it was a gray area and all of us were not sure whether we could legally actually practice telemedicine in the country. So these are very interesting guidelines, and the guidelines were very clear. So I'm just going to go through the highlights because it's almost a 35, 36 page document. I will just touch on the highlights. So first of all, it very clearly defined who is a registered medical practitioner as a person who could actually practice telemedicine in the country. It was anybody who is registered with the state medical register or in the Indian Medical Register at the national level. And this was as per the Indian Medical Council Act of 1956. Now the caveat here is that from the time that these guidelines come into existence, there is supposed to be certain modules that are going to be released by the Board of Governors who have taken over or superseded the Indian Medical Council. And those who want to continue practicing would actually have to take these modules. And going forward, to qualify as an RMP, we would have to undergo a qualifier before we could go ahead and practice medicine. So looking at that, we are already well into the 3 years. So this is something that we should be looking at going forward. Now, there are certain scenarios which have been discussed as to when and who can practice, with whom can you practice it. So these scenarios are basically that it can be a registered medical practitioner who's counseling a patient directly. He could be actually counseling the caregiver. There could be an RMP to the healthcare worker, RMP to another registered medical practitioner, and in emergency situations. So these are 5 scenarios which have actually been looked at by the telemedicine guidelines. Now, the type of consultations that one is allowed to do is basically, it can be a first-time consultation. It can be a follow-up consultation that you're doing. By a follow-up consultation, it means that within 6 months, we are doing a repeat consultation when the patient has already been seen with us or under a treatment. What it says is that in case there are any new symptoms, which are not a continuation of the old symptoms, or in any situation where the registered medical practitioner does not remember the context of the last consultation. In both these eventualities, a telemedicine consultation should not be undertaken by the registered medical practitioner. There are 7 elements which have been discussed. It talks about the context in which the consultation can happen. It is important that there is an identification of both the patient and the registered medical practitioner, in the sense that they both introduce themselves at the beginning. The mode of communication, because please remember, it can be, I can have a phone call, which is a voice, it can be a text, it can actually be a video consultation, it can be a combination of the modes. It can happen in 2 particular scenarios. That is, either it is a real time or it is asynchronous, where I have shared the details, or the patient has shared the details in advance, and then I go in for the consultation after all the details have been received by me. So it is actually happening in 2 stages. The next thing is about the consenting. Now, consenting part is important because you need to first identify whether it is a patient who's talking to us directly. Is it a caregiver? Is it a minor or an adult that we are consulting at that point in time? And now, very much like we do a consultation in the hospital, it is presumed that if the patient has initiated, it is taken for granted that a consent is in place. However, it is advised that we actually look at getting a formal consent before the start of the consultation. Also, it will depend upon the type of consultation that we are doing. It is important that we get a complete patient evaluation like we would do in a normal consultation. And then, of course, how we would go about engaging this patient depending upon the level of care that is required. In addition to all of these, there are certain caveats about the prescription. Now, it is very well defined as to how the prescription is to be written. But what we need to understand is actually what are the drugs that we can and cannot prescribe as per the guidelines. The categorization of drugs is very simple. There is an O category of drugs, which actually means over-the-counter drugs, which we would normally prescribe and we are allowed to prescribe. The second category of drugs which is there, which is the A category of drugs, which you can actually do or prescribe the drugs, which is a continuation in a follow-up. That is what you're advised to do. Now, they also suggest and what type of a consultation can we do this prescription. So while for the other categories, we can use any, for this particular category of drugs that we are going to be prescribing under the A category, it has to be a video consultation only, because at this point in time, it is suggested that the patient may be having new symptoms other than the ones for which the previous prescription was actually written out. The third category is actually your B category. And this would be a new consultation or new level of drugs that you're trying to add into it. And last category is, of course, our Schedule X drugs and the drugs which are coming under the narcotic and the psychotropic substances. So these are all have a high potential of abuse, and these drugs cannot be given as part of a tele-prescription, so to say. Now, these are the good things that we have some guidelines in place. Please understand that there are certain exclusions and things that we should actually be asking for clarity as we go forward on the telemedicine journey. One is, we do not have the hardware and the software, the infrastructure building or the maintenance part, which has been defined for us. So these have been excluded in the guidelines. Second thing is the type of data management systems that can be involved in terms of standards and the interoperability have also not been defined. Use of digital technology for the purpose of conducting any surgical or invasive procedures also is not allowed or not been defined under these guidelines. The other aspects such as research, evaluation, or education part, that is a telehealth part of it, has also not been covered. And it does not pertain to any kind of teleconsultation outside the jurisdiction of India. Another caveat that is there is that any platform, AI platform, that is your artificial intelligence powered platforms, where it is possible for the platform itself to suggest a diagnosis or a treatment, is something that we cannot use for the purpose of a teleconsultation. So this is something that we need to keep in mind. Also, I'm sure that all of us have experienced, for any of us who have actually tried the telemedicine, that there are 2 very big areas of dilemma for us. One is regarding the privacy of the consultation, because at the time of the consultation, it would depend upon where the patient is, where the doctor is actually sitting, the kind of people or the people who are actually walking in and out during the consultation actually going on. And the second part of it is, I think, the dignity that we all practice at the time of the teleconsultation. Where are we sitting? How are we sitting? What is our attire at the time of it? Both from the perspective of the RMP as well as the patient that we are consulting. So this is not to say that teleconsultation cannot be done or there are too many barriers to it. This is to say that this is the way forward. There are now some basic guidelines, and it is for us, and I'm sure Dr. Vidya will be defining later on as to what are the steps we should be taking to actually make it more robust and allow us to do more of this. So thank you, Dr. Vidya. Back to you.
Dilip, you started high acuity virtual medicine even before the telemedicine guidelines came out. So what made you, how did you feel when the court ruled against a virtual consultation?
They actually didn't rule it in a way that actually hurt us, because we were going according to the IT Act of 2000 and 2002 with its amendment, which actually did allow some form of telemedicine as long as you had consent and you had appropriate documentation in place. Those guidelines were very rudimentary, and even from 2000 and 2002 onwards, institutes such as Sanjay Gandhi, ISRO, the Indian Army, and on the private sector, Apollo, have been doing telemedicine in various capacities under the ambit of that law and that act. So again, I think when we dug further, we found that it's technically not illegal, but it's not been fleshed out in the degree that it needs to be. And then as I look at it oftentimes, sometimes, not sometimes, almost every time, you need to do something that is in the interest of a population, the legal framework often lags behind. And it may lag behind by years in some cases. Automated driving that Tesla and Google and other companies are pioneering actually drag the legal system behind them to make sure that this happens in the interest of the population. So I think some of that is certainly at play here, where the legal system will lag behind. But as long as the intent is correct and the beneficiary ends up being patient-centric, it's hard to find a situation where the law would actually object to it. And that, in some ways, is up to the guardians of the healthcare industry, which would be healthcare givers, such as nurses and doctors, to make sure that these boundaries and barriers are well defined, so that the legal system can actually piggyback on this and do a better job than they would have done without the healthcare industry taking the lead on it.
How do you do your consenting process, Dilip?
Sorry, Dr. Vasundhara, you had something to say. I'll answer that in a second.
Yeah. So, Dr. Dilip, I was basically coming in to say that I totally agree with you that telemedicine is the way forward, and especially given our population and the kind of reach that we require to deliver the healthcare services. I would actually appeal to my colleagues in the industry that, a lot of the times the law comes down hard on us because we actually tend to deviate, and we have a few people who do it and everybody else pays the price. So I think it is also up to us to really ensure that the good that we are trying to do is really in the interest of the population. So that is where I would rest my appeal and rest my case.
Vidya, could I butt in for a second? It's very pertinent.
Absolutely, sir. Yeah, it's all yours.
Vasundhara, you raised a very important point, and to me, for some time, it looked like you are talking as a lawyer rather than a physician, and that's the way it should be. Guidelines are always made keeping the least of the variability of it, and I can just relate it with the Organ Transplant Act. Sanjay Gandhi did first cadaveric transplant without any law. And I argued with luminaries, legal luminaries, before doing the transplant. The time was very limited. And my premise was there is no law for it, but there is no law against it. And we argued with it. And they advised me that don't take both the kidneys, take only one kidney. Because according to, they said that if somebody complains, it would be a big legal hassle, which you should be prepared, but we'll be able to bail out, as Dilip said, that your bona fide is not immoral or something. And we will say that if there is no law, it is not the fault of the society, it is the fault of the lawmakers, and in this situation go by the law of the land, like what is happening in other countries. Now, one point I would like to say, for 16 years I have been in a very tightly HIPAA protected environment, and now GDPR is the grandfather of HIPAA, and we do databases. And one thing which is universal there is the free will of the patient, and that is what is very important in this. In the same transplant example, that opt-out law of Singapore gave them more cadaveric organ. So for India, I think I would like you to comment briefly on the legal status, that if I have a freedom to give my data to anybody or give a consent to anybody, should we plead for an opt-out law, by wherein if the patient initiates a telemedicine consult, he gives his consent to the physician, and physicians are protected.
So what I would like to put forth here is that any consent, like we take even in the normal consultation or for a surgery, it works in a similar manner. However, for example, if I am doing the data, it would depend. So if it is an anonymized data, there is actually no problem there. But the moment that there is an identity which is attached to the data, and there is a data privacy issue which comes into play, if the patient is giving it to us, then it has to be very definitive as to what I can do and cannot do with that data. And there should be an opt out from the consent as well. Because if you're talking about free will, if I feel that my data is...
Exactly, that's what I'm trying to say. That we cannot assume that since the patient asks for a consultation, it's all covered. Now we should be working, because in India, I have been equally practicing with Indian patients. 90% of them are not bothered about these issues. They have a problem, they want to consult, they send you the data as you want it. So I would say that we should rather work on that area to secure a physician where the patient is willing to give a consent. It is something like signing a disclaimer for Google or Apple. Nobody looks at 10 pages, said, I have read it, and you agree to all that. So I think that's the point which I don't want to take too much of time. Vidya, thank you. We can talk for hours, but
if I could interrupt, the good news is that the telemedicine guidelines are being revised, and one of our JIPMA alumnus, Dr. Nalin Mehta, and another batchmate of mine, also they are all involved in that. So hopefully we'll be seeing some, revision which will go take telemedicine forward. So going back to you, Dilip, how do you do the consenting when a patient calls and asks for a consultation? We are saying the consent is implicit. How does that work in tele ICU?
Yeah, so in the outpatient space, what you said is right. However, I do foresee a consent manager that is mandated by NDHM to go live very soon. People are working on that sandbox as we speak, and that is the right way to go forward. In the ICU space, we have an agreement with the hospital where a consent for telemedicine is taken a priori at the time of admission in a detailed format, just like you would take consent for other procedures that are part of the ICU as standard procedure. Of course, there is a right to rescind that at any point in time. And we share a list of all our doctors and their qualifications with the hospital as if we are empaneled doctors in that hospital. So the consent is built into that as if we are a team of that hospital, which we are, and that is the right way to do it. Because you want to be providing consent with certified providers, credential providers in that hospital. So once that is in place, then they know that they're being monitored. They have consent for video monitoring and for care that is augmented in addition to their doctors at bedside. So very explicitly, we state that this does not mean, the hospital states actually on behalf of the platform, that you are going to have doctors at bedside. This is an augmentative service and does not replace bedside care.
Right. Thank you, Dilip, for that clarification. Next, I would request Dr. Geetanjali. She's the director of All India Institute of Medical Sciences, Bhubaneswar. As the head of a government institution, what has been your stand on virtual medicine, Geetanjali? What was the status of telemedicine at AIIMS Bhubaneswar before the pandemic? Did you step it up during the pandemic? And do you expect to continue providing telemedicine services after the pandemic as well?
Okay, Vidya, good evening, but I'm not able to switch on my video because it says the host has stopped it. So if so, you'll
Dave,
have to
could you
just.
help? Dave, can you
Dave,
help get
Dave,
Geetanjali's video back
can
on?
you give access?
So it's okay. I will talk just to save time if someone can't manage this. So I don't know why it's not coming. So okay.
I have given you. Now you try.
Okay. No, sir, it's not working. It's all right, sir. I'll speak. So thank you very much for giving me this opportunity. And I don't have very exciting things to tell all of you, but I just want to say that when we started out, I mean, ours is a kind of,
Please,
it's a
please
public
try
hospital.
it now. Now you have.
Yes.
Now you have.
Yes. So ours is a public hospital, and like most government hospitals, we don't spend much on the infrastructure, on the IT infrastructure. And AIIMS Bhubaneswar was no different. But we had a kind of a rudimentary system where we were doing the registration. There was a module called Mera Hospital, where we could get the feedback of patients which were recorded. And so we could sort of compare ourselves with the other new AIIMS, all the new AIIMS. This was pre-COVID area. But this was because this whole platform was free from the national NIC, or the National Informatics Center. And it was not very good. We couldn't proceed because they were not interested in taking the whole thing forward. And so we moved on to another platform which was offered by another governmental agency called CDAC. Right now we are with them, and this is much, much better. But however, our whole thing was towards an electronic, kind of medical records and things like that. This was still the COVID came in. So once COVID came in, we had a huge problem, because we see about 4,500 to 5,000 patients every day in our OPD, and each patient comes in with another 2 or 3 people. So it was a huge number of people, and so we had to stop our walk-in OPD so that we could, prevent COVID spreading amongst patients, from patients to us, because at that time there was no vaccine and things like that. So we needed to have a kind of a platform which we could offer to these large number of patients who needed to come in. So we started a very simple telemedicine service with ordinary phones. We just put some SIM cards, gave a few, pads to every OPD, and said, so any patient who could ring up would ring up, and they were speaking and giving some kind of advice. Then our IT department came up with what was called an AIIMS Bhubaneswar eSwasthya app. It was just an app, a free app which they could download from the Play Store. And in this app, people could upload their, some diagnostic tests if they have done, or they could take a photograph and upload it. And similarly, the physician also could, send the prescription and things like that. So if we looked at, even now that we are sort of coming out a little bit from this lockdown and all that, in 1 month we see about 15 to 16,000 teleconsultations which go on. This is only for our OPD. So this was something which we are doing. Mostly this every OPD is having this kind of phones and tablets which the residents as well as the faculty are seeing. So many patients are quite happy with what is happening here. And the thing is, because there was almost a total lockdown, so this is one way in which they could communicate. The other things which we are doing is, I would say that once the COVID pandemic started, patients' relatives could not, sort of go into the ICUs and, wards. We were very strict about that. And so there was a huge problem. So what we did was we trained some MSc nursing students, gave them again some tablets, and they would go in and sort of speak to the patients and be like, also talk to their relatives outside. So we did a whole lot of things like, we had some telephones which were put outside, and we could give a phone to the patients inside and so on. So we were trying a whole lot of things. Some worked, some did not work. But by and large, this was one of the things which we needed. Also, if you look at our hospital, within the ICUs, we were not having good connectivity. So these are some lot of problems which we were having, even, what we take for granted, like a good connection or a good Wi-Fi connectivity was not there. So we had to scramble and, sort of, do those things so that we could at least, many times we, a resident inside a ICU, COVID ICU, even if we wanted a faculty member to come, by the time they would dawn, it will be another 10 minutes, and we had a separate building. So to reach the building, it was far off and so on. So these were some of the issues which we had, but I think we could manage because we used to have a regular feedback from the consultants, the residents. I used to take almost meetings every day. So we didn't lose time in sort of trying to figure out what went wrong and see how we could, sort of address the issues which we were having. But one of the things which the government has done is they have also set up what is called e-Sanjeevani. So this e-Sanjeevani is like this hub and spoke model, especially in Orissa. AIIMS Bhubaneswar, we deal with 6 districts, and in these 6 districts, we have what are called 100 spokes. So every day for 2 hours, we have a kind of a timetable where a physician at AIIMS Bhubaneswar connects with another physician and a patient at a far off point, at one of the districts, in the primary health center, or sometimes it is a district hospital, and they are able to, have a consultation. It's not taken off that much, but it started only in June. So if you see June and July, we've done about, I think we have done 211 consultations. But I think this has potential because we are able to reach areas like very, very far off, and which hardly have the people there don't have access to good healthcare. So this is working out in a fairly, if we are going to fine tune it and be able to have a kind of a triage system to make sure that the patients who are being hooked up with the consultants here are those who need that kind of a consultation, I think it would be a very good thing. But in that way, we are kind of supporting the healthcare in the district level. One of the other things which are working well is also called e-Rakt Kosh. That is this blood banking. They have, it's being connected with other blood banks across Orissa. And of course, it's at the national level also. So we are able to, especially during this COVID times when, the blood donation came down, we could go and everyone knew what our inventory was, and all the blood components and everything people could find out. So we could get blood from each other blood banks. So that was a good thing which was going on. So this is what I have to say about what's going on in at the for the public hospitals in India. Thank you for the opportunity.
Thank you, Geeta. Up next is Dr. Hetal Kumar Vadera. He's the head of the Department of Anesthesiology at Sterling Hospital, Rajkot. Most of us wondered how we could help as the first and second waves of COVID ravaged our country. Many of us were roped in for hospital care, and anesthesiologists were deployed in the ICUs. But Hetal and several doctors went beyond that and reached out to the community. Hetal, please share your experience.
Thank you, madam, for kind introduction and inviting me for this session. As you said, it was like a social service. Initially, when first wave started, there were patients who were getting treated at home, but not getting physician's advice because physicians were too busy in ICU as well as in wards. So one of my relative got COVID infection. She had COVID. She got some medicine from civil hospital, but she was not getting any help from local physicians or intensivists because they were too busy. When I saw this, I thought of starting a helpline for patients who are not getting help from physicians. So I talked to a few of my friends who have a similar thought process. Most of them are anesthetists, and 13 of them agreed with me to start a social service. We drafted a message with our phone numbers, which are WhatsApp numbers, and circulated on WhatsApp as well as on Facebook. Uh, and immediately it went viral because many patients were not getting help because of too many patients in the area, and physicians were too busy. So we started this initiative. Patients were sending message on WhatsApp. What we were doing, we prepared some videos on YouTube with some basic informations like how to take care of a patient at home, what are the investigation, how to use thermometer, how to use pulse oximeter, like that. We prepared some flyers also. So once we get the message from patient, we were sending these flyers and videos to the patient. So many of the things were sorted out, but still they have few questions. So we allowed them to call us once they see the videos and flyers. Then daily we ask them to send vitals, chart of a vital. We taught them how to maintain a chart of vital, that is of temperature, pulse, and SpO2. So they were daily sending us vital chart so that we can know whether patient is stable or deteriorating. If patient get deteriorated, then we were asking them to get hospitalized. We were advising some investigation at regular intervals so that we can see the progress of the patient. And during first wave, I think most of the patient got recovered at home only. Severity was less at that time. Between first and second wave, we, with same patient, we started to motivate them for vaccination. So we prepared few videos about vaccination. There were some myths about vaccination, so we tried to clarify those myths. So many of the patients took the vaccine. During second wave, again we started the same helpline and helped almost more than 2,000 patients during second wave in the area of Rajkot, as well as from around the Gujarat also. We got few calls from Bombay, Bangalore also, who were Gujarati. So many patients got help from this initiative. We were giving them advice about what diet they should take, how to remain fit, some psychological support, and it helped a lot. So this is how we helped many patients. During first wave, we treated almost 1,000 to 1,500 patients, and during second wave, we treated more than 2,000 patients.
Thanks, Hetal. I'm just going back for a quick question to Asundra. You talked about RMP being the person who's registered in the state or the Central Medical Council. So is a person registered in one state allowed to practice telemedicine with a patient in another state?
So as per what the guidelines say is that you have to be registered in a state and you can practice it within the jurisdiction of India. That is how the guidelines.
Yeah. Thanks for the clarification. Next, we have Mr. Harish Manian. He's the CEO of MGM Healthcare at Chennai. Harish, as the head of a private healthcare organization, what are your thoughts on the utility, financial viability, and future of virtual healthcare? Harish, are you there? Harish, you're muted.
Yes. I got it right here. So thank you, ma'am. Thanks for having me. Thanks, Dr. Mahindra and Verticity Foundation for having me as part of this, August gathering of really great speakers. Actually, thanks. It's good in a way that I'm coming at this time to speak because most of the topics have been covered by all the speakers. So my view on this entire journey for the last few years, I started working for telemedicine from 2004 onwards. When I was in Manipal Hospital, I joined there as the head of telemedicine in 2004. As Dr. Mahendra mentioned earlier, there were challenges when we started in the earlier stages with regards to bandwidth and the connectivity issues which we used to face. The only achievement during that time and only significant player which could give us substantial bandwidth at that point in time was ISRO. So we could do some work with them. Post that, I think after 2 decades, when I'm working with an organization like MGM, in this setting, we saw a lot of things which has happened in the last 18 months, which has forced certain technological changes which came into place. We used telemedicine for at least 4 or 5 segments of our patient services. First was for consultation, which we used, and the platform which we used was from Zoho, which was Charm, which we used for actually consulting all our patients. What we saw during this entire COVID period is that immediately when the phase 1 or the first wave of COVID happened, all our work got completely dried up. The OP numbers were practically come down to single digits. And at that point in time, we implemented our telemedicine platform. In fact, we had something at a very nascent stage, but we integrated payment gateways and also had a EMR system built into it so that it can talk seamlessly and get patient enrolled into the overall thing so that we should not lose track of patients. So the immediate requirement when the phase 1 of COVID happened or the first wave happened was for us to engage with all our customers and ensure that they are not losing track of the treatment. And this platform helped us big time. And at that point in time, I think we could do at least almost like 400 to 500 consults in a month. During the same period, we launched what you call as home healthcare, which was our package for COVID management at home, which was also a tech-driven activity, which was used for managing patients in COVID at their home. And that platform was again like a command center in-house facility where the nurse and the physician used to talk to the patients on a regular basis, take the vitals. So that platform was also being leveraged using the same one. After that, the one which was used was for patients who were in ICU and for the patients and also for the relatives of the patients who are away from them and not able to communicate. So we use the platform, not a formal telemedicine platform, so to say, but we use the informal telemedicine platform to communicate between the patient, the doctor, and the relatives who are at the remote location, because they are not able to access the patient on a regular basis because they were in COVID. So that's one more avenue. We created a command center exclusively for patient management and communication, which was used to give vital information about the patient, the journey, how it is going on when he is inside the hospital, so that they can be managed pretty well. And the fourth one was teleradiology, which we very effectively utilized during this period because there was a large amount of patients coming during the nights for scans, and CT chest was one of the areas where people was a gold standard for screening them for COVID. So we actually used that, and there were times when we have done almost like 15, 20 CT scans in the nights, and all were reported through using a platform. So these are the 4 segments as a private sector which we have used very efficiently in the last 18 months. The way forward, what we feel is what Dr. Dilip mentioned, and we are also working along with them to create a model for ourselves, wherein tele-ICU is going to be one more platform which we are going to enable as things move forward. Looking forward, we are also looking at an app which has to be enabled so that if at all this entire progression happens in a different direction, we have a much more simpler device which people can use to connect to our system and talk to our doctors. So that's one more avenue which we are exploring, and we are trying to launch it very soon. So I think that's a journey which we have seen in the last 18 months as far as technology. Some of the specialities have actually moved, have shown great affinity towards telemedicine. Even during the, of course, they adopted technology when COVID was happening, but post-COVID, now those specialities are using telemedicine more efficiently. I think some of the specialties like psychiatry, dermatology, internal medicine, OBG, and neuro are the ones which are actually, we are seeing good trend lines in terms of patient uptake on the online platform. So these are things which are helping us, even as we speak, almost like 10 to 15% of our current consultation volumes on a month-to-month basis are still sustained through telemedicine. So we do a consultations volume of almost 8 to 10,000 a month. Out of that, still almost 700 to 800 to 1,000 consultations happen on online platform. We have dedicated days we have defined where doctors do teleconsultations in-house the hospital. So this is actually a platform which is helping us stay in touch and also ensure that we are not losing track of the patients. That is one. Second, it also has given a lot of convenience to the patients to talk to our doctors sitting at their home. There was one point which were raised during this conversation about legality. During this entire course, I don't know how many hospitals have got any legal or so to say a complaint from a patient from a legal standpoint. I think there were very few hospitals. One example I got to know was one of the hospitals where they got some complaint on teleconsultation where the patient had some issues. So they have raised a complaint against the hospital saying that you guys didn't give the right information. But the problem was at that point, when the aged patient at the home, the communication was done by a son instead of the patient himself. So there was some gap in terms of communication, which is actually a gap in telemedicine itself, if I feel, because a patient who is bedridden, the family communicates whatever that doctor understands at that point in time without seeing the patient. It becomes slightly tricky in an Indian context. So, but we had some documentation which we scrutinized through this doctor, and then we could understand that there are these kind of situations we should be wary about as an organization looking forward. So that's some learnings which we felt. Even now, as we speak, almost 80% of our telemedicine volume still lies in the unorganized, platforms like WhatsApp, Zoom, and your Skype. So still way to go as far as telemedicine is concerned. I feel that as early as we adopt the technology and we continue to use it, because as things normalize, people will drop the technology. That's what the fear is almost. But I feel if we continue to utilize this, this is going to be the norm moving forward. And mostly, almost 25 to 30% of your OP volumes can be optimized using telemedicine in the current setting, and that's where the way forward is actually. And I think most of the hospitals are reaping benefits out of it as we go forward. So that's my view on the current setting of telemedicine and what's happening in our journey so far, what we have seen. I think there is a lot to desire, a lot to achieve. I feel there is a long journey ahead. Regulations are one few part of it actually. I'm also part of discussions with some of the major insurance companies in terms of how we can ensure there is a seamless integration between the patient who is getting a teleconsultation to an admission in a hospital in a seamless way. And that process is on. But as we speak, we could actually, during this COVID period, we have ensured few of the insurance company, we made representations and made sure that home teleconsultation and COVID management through telemedicine was reimbursable. And now, as we speak, I think teleconsultations are also reimbursable through, some of the insurance companies, which is used especially for COVID and otherwise also. So there are progressions happening in both sectors, and people are taking it progressively from an insurance sector as well. So things are looking good, as many speakers pointed out, that there are legal gaps which needs to be plugged in. And as the product matures, legal system will also catch up with the current setting. And we look forward to making technology more viable and more acceptable in the healthcare setting. So that's my learning and my view on the current situation. And thanks for having me as part of this discussion.
Thanks, Harish. You preempted my question about what the response of the health insurance industry has been. Thanks for that. Dilip, what has been your experience with insurance reimbursements in tele ICU?
Well, things are a little different in the US. In the US, entities are moving towards actually paying for the service, which is a welcome development. So globally, the move is going to be towards actually monetizing this and having a payer pay for it, be it insurance from the private sector or the government. In India, we haven't dealt with them in as much because the model is that the hospital would pay the service provider as a service that's provided to the hospital, like a B2B service. So we have not interacted with insurance agencies in this space as of now, but we are seeing legislation and seeing movement in the same direction as Harish pointed out. So it's a matter of time, I think, before that happens.
Lastly, I welcome Dr. Anant Pai. Thank you, Anant, for joining at literally the 11th hour. I'm sorry to say that Dr. Vishnu Vardhan, who was supposed to join us, is not well, and Anant was kind enough to step in at the last minute. He's He also works with Vishnu. He's the Director, Clinical Operations and Pathways of Care 365 AI. Anant, I understand yours is a new company. What made you start it, and what other business opportunities do you foresee with increasing use of telemedicine?
Thank you, Vidya ma'am. Am I audible?
Yes.
Okay. Thank you, Vidya ma'am. Coming at the end of the conversation, I feel a lot has been covered, and a lot of giants have already spoken. So it's very kind of the Marvelous Medicine and the Vattikuti Foundation to have given our company, a startup, this opportunity. So now I have been asked to talk about the business models, or what are the business availabilities, business propositions in virtual medicine in India. So, well, uh, everybody's spoken about how it can be done, what can be done, what cannot be done. But now the fair enough question, or the $1 million question would be, who is going to pay for it? Is there money in it? Can you put a price tag to virtual medicine? Is there a financial transaction in it? So I would like to just express a few views here. Now, first and foremost, in order to create a business model, we would like to see, are we selling something? Is there a product that we are selling, or is there a service that we are selling? Now, once that is done, we need to know to whom are we giving it. So there is a consumer, and there is a product or service for which there is a financial transaction. That's the bare basics. Now let's go to who is my consumer. For virtual medicine, who is my consumer? Is it the patient? Is it the patient's relative? Or is it a doctor? Is it a healthcare organization? Is it the insurance? Is it the government? Someone has to pay me money for it. So let's go back to the post-COVID days, what we are seeing now. Eating out has become a sort of a very rarity. However, most of us still do get to eat our choice dishes from our favorite restaurants, thanks to Swiggy or Zomato. We are still doing our fair share of shopping, and in fact, much more sitting at home, thanks to Amazon, Myntra, Flipkart. Okay, so e-commerce, EduTech. Byju's has become a billion-dollar company providing good quality education sitting at home. Now let's look at it this way. I am following my hobby classes, my Hindustani music classes, sitting at home, which was something of not thought of pre-COVID. What is happening in the healthcare scenario? A few statistics here. 6 crore households. It's a very small number, but the money in it is still big. 6 crore households have started doing their shopping for pharma on an online basis. 32% of consultations in the country at the level of a family practitioner and at the level of a specialist, typically an internal medicine specialist, have been happening on an online platform or a virtual platform. So what we see here is there is an element of service, and then there is a product. Now you put them together in different permutations and combinations, you develop your solution, the entire virtual medicine solution. So you may have a patient who is paying you the money directly, or you may have a doctor or a group of doctors using your solution and paying you money directly so that they can use this solution on their patients. Or you still have a larger organization like an MGM, like what Harish told just now, which is a healthcare organization, which has got a band of doctors, a huge group of doctors. They are using this solution on their patients, and the healthcare organization pays me money. So you see, there are various methods that the business proposition or a business model can be centered around. So what does a patient need? The patient needs A good doctor, number one. It needs a good hospital. It needs pharmacy. It needs lab. It needs radiology. Then you need the ancillary services like dietetics and physiotherapy, etc. Now, is it possible to deliver all this on a virtual platform? Once you can do that, you can definitely put a price tag to all these services. But a word of caution here. The first consult, like what my esteemed colleague, Dr. Rajkumar said, typically needs to be in an office encounter, because in medicine, there is an element of physical examination. There is a man-to-man contact. There is a personal touch. Now, this is very important, extremely important to garner the trust and the confidence to go ahead in the treatment. However, on most of the other follow-ups, there is limited physical contact, and an online or a virtual consult is definitely possible. Now, these can be monetized from an individual doctor perspective to create an online business platform. Typically, general practice or a family medicine, psychiatry, diabetic clinics, nutritionists or dietetics, they have built a pretty large business volume on an online format post-COVID era. These are very amenable to telemedicine. They fall very well under the clauses what the MCI or what the Indian Medical Council has put. So you have a good business model there. You are doing it well under statutory conditions, so they work extremely well. However, in order to grow this bigger, we need to look at a pyramid. So the pyramid is that of what are the different possibilities of delivering revenue or business models. The base would be that of what we call as care navigation. Now, care navigation is wherein somebody wants to try and find out which doctor to go to for what problem. Now, these are available on several different companies have done extremely well in this, and lot of patients coming into the hospital come through these companies. These typically work on something what we call as a subscription model, wherein either a doctor or a hospital subscribes to the services of this virtual medicine platform to navigate a patient into their hospital. Similarly, you can have an online booking of an appointment, a confirmation of an appointment, and even a telemedicine or a virtual reality online consultation. Now, these softwares work again on a subscription model such that either a healthcare organization or an individual doctor pays the company for the services provided. After the online consultation comes the part of pharmacy. We have seen a huge big rise in the graph of people using online pharmacy to buy their medicines. Now, first part is just buying the medicines. So what comes next? If enough data comes in, there is a lot of intelligence generated as to the buying habits of medicines or the prescriptive habits of physicians. We can come in with medical reconciliation. We can bring in adherence reports. We can do adverse drug reaction monitoring. These are the other revenues or opportunities. Now, the last but the top of the pyramid, which is to do with an online ICU, okay, which we call as specialty services, and what large healthcare organizations like MGM, like what Harish said, are utilizing today, what the AIIMS Bhubaneswar has done. So they make use of specialty services. Specialty services can be in the ICU, can be a cloud physician, an online outpatient consultation, teleradiology, laboratory services. These all come under on the tip of the iceberg there. Now, how do they generate revenue? They generate revenue typically on a B2B model. So what I would like to say is virtual medicine, the different business models that can be generated around it can be as simple as a Google Pay payment directly into the wallet of the doctor, which is a direct B2B, a business to customer. You can have a business to business, or you can have a large scale business to a smaller software or a technology company, which delivers then to the customer. So the possibilities are numerous. What is important here? In order to get that revenue, you need to give something called as value. So what is the value proposition that you are delivering? First and foremost, post-COVID, we have understood that in India, our healthcare scenario or our healthcare infrastructure is not exactly up to the mark. We have our loopholes. We are, what can we say? We are deficient in terms of manpower, in terms of availability, in terms of infrastructure. What does tech do? If we are able to deliver the same value, tech or technology can give what is called a scalability. Now, the value proposition should be that the virtual consult should give you the same experience as a traditional in-office interaction to as far as possible. Now, technology will be able to scale it. Now, whereas one surgeon can conduct one surgery at one given point of time in person, technology can deliver this to multiples. So a good solution should be able to serve the society at a much larger perspective, therefore providing a much larger business proposition. So a virtual consult.
We are running out of time, Anant. I'm sorry, Amit. We are really running behind time. We need to.
Okay, ma'am. I will.
Sorry.
Okay, I will just close up by saying.
Yeah.
I will just close up with saying this much, that the National Digital Health Mission under the Government of India, Ministry of Health, it's a plan to digitalize or put a lot of things like the Aadhaar. Okay, the clinical data, the clinical history, service records, e-pharma records, financial and insurance details of a patient on a digital platform. Now, this will put all the healthcare scenario of our country on an overdrive, providing accessible, available, and affordable healthcare to a large amount of population and developing it as a big business industry in the next decade. So I think that's all that I have to say.
Thanks, Anand. We have Dr. Arun Nandi, who's an emergency physician, as well as he's faculty in the global health as well. So, Arun, what would you like to say about how telemedicine is going to help global health?
Vidya, thank you very much for including me. And I want to thank the foundation also for giving me this opportunity. Can you hear me, first of all?
Yes.
Good. Excellent. So I think we've had a very robust discussion on this whole topic, and we've covered probably every possible angle of it. But I think it boils down to what Dilip had initially said with this iron triangle. This is going to be the future of medicine, undoubtedly. But like every new venture, whether it's going to be in the US, in India, or globally, there's going to be the iron triangle there always. And I would just like to change it a tiny bit. I would say adoption, accessibility, and finally, monetary compensation. Those are going to be the three pillars on which this whole new technology is going to depend. There is no doubt from this whole discussion that this is the way forward. But we've seen many things in which it was truly the way forward. Robotic surgery was the way forward. Laparoscopic surgery was the way forward. Preventive and social medicine was a way forward. Community medicine was a way forward. All of these have taken time to adopt. We have a crunch on us because of COVID. And like Dilip also said, we've accelerated our progress. So I think we'll have these three pivots on which everything is going to depend. To answer your question, Vidya, about global medicine, I've been active in global medicine, in emergency medicine, and also in telemedicine to a great extent over here. And we got thrown into it very much like everybody else did. Post haste, when COVID arrived, everything had to become telemedicine and the platforms weren't ready. So that first piece of adoption was very difficult for us, even in the US. There were so many platforms, some were ill-equipped, some were not so well, some were well-equipped, but didn't have something else that the patient had to offer. The patient piece was very hard to adopt. But I'll tell you what I found most useful as an emergency director of, of operations here. We had applications in the pre-hospital care piece, which I haven't heard so far, which was really important. When COVID hit New York, where I was based at Mount Sinai as the director, we had patients that never made it. And our EMS providers in the field recorded an upsurge of 131%, of which the death rate was close to 50. So they said, Doc, we're reaching they're almost all dead or dying. And they did not have the capacity to actually tackle these situations. They'd never seen something like this before. That was our first input in which we actually put our doctors to work with the EMS providers in the field to give them advice. So that was an example of telemedicine being put to work quickly and effectively. Second place was triaging. In the front, because we had to have a contactless experience, triage was so important to us that we had to separate the sick COVID and the sick non-COVID initially. Later on, it became, a moot point because everyone was COVID. But initially, it was really important to distinguish who was really sick, and we used that in triage. Then, at the third step, inside the emergency room, we use it both for treatment, and we also use it for follow-up, which is we used it to talk to patients. We had an iPad inside, an iPad outside, and the patient could actually talk to us because the amount of PPE we were chewing through by going to reevaluate patients was just not there. And despite everything that you might think, we were asked to reuse masks in the US, which was a paradigm shift I'd never seen. So we saved on a lot of equipment by having these interactions telephonically or through the iPad. And the last place was also follow-up out, when the patients got discharged, if they got discharged, whether from the ICU or from the ED, emergency department, that we could follow them at home. So these were the kind of 4 broad brushstroke applications during COVID. Post-COVID, we realized that all the equipment that we had gathered, including those amazing cameras that I saw in the beginning of this presentation, were very useful for every presentation that was visual. So dermatologic, ENT, and ophthalmologic consultations, which are very hard to get immediately, were available. Stroke also was immediately available to us when we use these in that context. Expanding to the global situation, I've actually dealt with 2 other countries, Sri Lanka and Tanzania, where we have leveraged this technology for 2 things. One is to actually teach the existing troops on the ground how to handle just regular everyday situations. And thirdly, to provide consultations in difficult cases. And we have situations in which, they'll have a difficult case. And we've had during COVID, both the Slack channel open and also cloud-based video chatting through which we've been able to help our physicians in front hospitals in really rural areas in Tanzania, in Kenya, and also in Sri Lanka. So I know we are at the end of our extremely very valuable discussion. And I think telemedicine is here to stay. We just have to make it viable.
Thanks, Nandi. Giridhar, as a practicing ophthalmologist, what has been your experience with telemedicine?
Can you hear me? Can you hear me, Vidya?
Yes, yes.
So I'm not really a practicing ophthalmologist. I actually am in charge of a government eye hospital with 75 beds. So I was just wondering, among all the platforms available like WhatsApp, Zoom, can we use this meeting sort of platforms for telemedicine within the hospital? For example, there is an emergency and the junior resident is seeing the patient. Can we keep the Zoom meeting on and if the junior resident wants a consultation with the assistant professor or the unit chief, and if the Zoom meeting is on throughout the day and the night, will it be a costly affair or it's just like any other connection? So probably I would ask Arun Nandi to first say that. Just heard him and he was telling that he has worked in Sri Lanka and Tanzania. So India is probably in a similar situation. The cost is platforms to be on throughout the day.
Dilip or Akash, would you like to take that question?
Yeah, sorry, what was the question again?
If for in-hospital use, what would be a useful platform to keep running through the day? Like
yeah, so any one of that's what I heard the first half, but yeah, any one of these are actually satisfactory. The only key that you want to have is they need to be compliant with the data security policies. Many of them actually have 24/7 solutions, including Zoom, Google Meet, Microsoft Teams. They all run 24/7. Some of them are open source also. One of them is called Jitsi, JITSI. That's also available for regular use, but it's all going to circulate around the privacy laws because some of them are not actually HIPAA compliant. Now, HIPAA is not an Indian law, so we don't need to hold ourselves to it. But at the same time, having this as a information to keep in your back pocket is going to be valuable. That said, continuous streaming of video needs to be done with a purpose. So I think if the use case is a certain a priori, you can then decide whether you want it as an on-demand video or running it 24/7, which does have constraints on the data bandwidth as well.
Yes, we are close to closing time. So Radhakrishna or Ravi Shankar, do you have any quick points to make? And we'll be winding up. We've been here for 2 hours now. Unmute yourself. Yeah.
Yeah, sorry. I was just going to say that this has been extremely fascinating. Obviously, all of you, many of you know my background. The only question that I was going to ask is that this is very reminiscent to me of working remotely in my current job role. And one thing that has happened is that there is really no work-life balance in the sense that, work spills everywhere. What happens to people who've been doing this virtual medicine, when you at least in the past, when you went home from your clinic, you didn't carry your work with you to the same extent as it was working in the clinic. But right now, if you have your device with you, it could be 24/7. So has anyone looked into that? Is this, are there any studies from anywhere at how this affects work-life balance and other psychological parameters in the practitioners?
Can I comment on that?
Yeah, please go ahead.
Yeah, we do have data on this internally. So some of our ICU providers, for I think the first time in their careers in India, are able to take a 12-hour call for the tele-ICU network from home or from any workplace that they choose. And the satisfaction and the stress levels are certainly lower when they're at home because they're in a familiar environment. And Bangalore is nationally famous for its traffic. I don't know how famous it is in the rest of the world, but certainly traffic is a major time hog in Bangalore. So their productivity is in fact pretty good in this phase. Now, from the IT sector, there is data that a work from home environment almost presents itself to no clock off time once you have a clock on time. But the medical industry has functioned on a clock on, clock off for decades now. So I think that insulation is built into the system. So we sort of insulate our clinicians, doctors and nurses from this as much as possible. That said, COVID sort of threw all the data and the guidelines completely out of whack. So it obviously changed a few things, but we're limping back to normal. But from a work from home or work from your preferred location standpoint, I think telemedicine may actually be an enabler. And it is imperative upon the providers of healthcare and the people who are actually taking the care providers on their platform to ensure that the personal lives of these individuals are not sacrificed just because you now have an easy access to high quality service. So those guardrails need to be set right. Otherwise, there are perils at stake here.
Vidya, may I just?
Yeah, okay.
Arun, this is Arun here. I just wanted to actually agree with Dilip on that, in that we have to police ourselves in many respects. And one of the things that I faced with my providers and my doctors when I started this was this fatigue that came in, and people were obliged to keep their phones switched on. And we developed a system of handing over as soon as our shifts were over, just like we would do normal shifts, and we handed over our virtual calls to our next colleague. But on the other hand, satisfaction of not having to navigate New York traffic, or the frustration of not having to be on, there all the time and being in your own environment actually increased productivity. I wouldn't say so much in the ICU setting, but in the consultation and in the setting of EMS, it definitely increased our productivity. We were able to do more from far than near.
We have Dr. Krishnan Sriram, who also is a tele-intensivist. Dr. Sriram, thanks for joining and your thoughts.
Yeah, so thank you for asking me to say a couple of things. So as you know, my background is mainly in telecritical care and in telenutrition. And based on that, people have on patients. The thing that has actually concerned me is that we heard from Dr. Pai about the value added to telemedicine. And we have to make sure that the advice we give on the telemedicine platform should be value added. And I've seen all kinds of wrong advice being given to patients, and they are charged 2,000 rupees for a 10-minute audio consult, which actually is
lost the audio.
So I need to say that we have to be very sure.
Dr. Sriram, your internet connection seems a little unstable. So Pata, a few words and then we'll say goodbye to everyone.
I think it's been a wonderful session, Vidya. I think there should be first of the many on the subject likely to come, because I think it's opened eyes to telemedicine to many of us. And I understand from the discussion that in India, we are still in infancy of telemedicine. Although there are islands of excellence, especially in the private sector, I think there should be a lot of cross-pollination of ideas, and we need to upgrade telemedicine practice. Actually, all of us as physicians, we've been bombarded with questions or a need for teleconsultation, which we do not know how to go about. As Prabhakar is saying, that there are issues with connectivity and monetization and so on. I think it's time, and COVID has given a good platform for us to all put our ideas together and move forward, and in possible meetings which are likely to come up in due course, we'll be much better off. And actually, I think you should thank Dr. Mahendra Bhandari.
And Cooper.
and the Verticality Foundation for making this possible. Well done, Vidya.
Thank you once again, Dr. Bhandari, for providing this initiative to take this. This is the first time we've done a panel discussion on marvelous medicine. Usually it's easy to just find one or two speakers and a moderator, but this was a challenge. Though we have done panel discussions in conferences in person, this was my first experience of doing a panel discussion on the virtual thing. And all the panelists were, though they are very senior, very busy people, they were very kind to spare time with me, and I literally nagged them, for days together, and hope the end result has been worthwhile. Thank you each one of you, Akash, Geetanjali, Hetal, Dilip, Rajkumar, Prabhakar, Vasundhara, and especially Anand for joining at the last minute, and Harish had to leave because of some problem, and we hope that our colleague gets well soon. Dr. Bhandari, your final words.
Yeah, Vidya, thank you very much. You revised my opinion because I always am wary of having too many people to talk, because when you bring too many experts, they have so much to say. But I must compliment your panel. If it worked because the kind of people you brought. They had hands-on experience. They were not cut and paste or Slidoria kind of people. They had their personal experience of not only telemedicine in their area, but also.
I think Dr. Bhandari is.
So when this happens in telemedicine, you pick up the phone and call. Typically,
I have been what you call regular audience to your session. So please, we will think about bringing some more topics which are of public interest, and is not only, as I said earlier, is not only for us to know, but in order to move public opinion when the new telemedicine guidelines are done. These sessions are not ignored. If the panel has, a real job to do, they must take that into account. Thank you very much, and goodbye, everybody. It was a little longish panel. Nonetheless, it was very, very fruitful as far as I'm concerned. Did give me a latest of what is happening. Thank you, Vidya.
Thank you. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night, everyone.
Good night.
Thank you, ladies and
Thank you,
gentlemen.
everyone.
Thank you.
Good night, ma'am. Thank you.
Thank you.
We will have this video available in the next week or the following week on the Vedikuti Foundation website. And I'm going to try and break it up into individual segments so that people can look at just a shorter chunk at a time. Thanks for joining us this evening.
Thank you. Thank you, Dave. Thank
Bye.
you, Giovanna, for your patient monitoring of the audience. Thank you.